Hello, good morning, everybody. My name is Dr. Gaurav Mishra. I'm a child, adolescent, and adult psychiatrist, and I'm really excited today to welcome Dr. Dan Ariely, who's a behavioral economics researcher, author of several books that help people understand the science a lot better. Recently, I've read his two books, Irrationally Irrational and Payoff. Really excited to talk to you, Dr. Ariely.
My pleasure. Lovely to be here.
Can you tell us a little bit about your early life and journey towards behavioral economics?
Yes. So it's not a happy story. You read some of my books, so you know the story. I was badly injured many years ago. Um, just about to turn 18, 17 and a half. I was injured. I was burned in 70% of my body. I was in hospital for over 3 years. This is why I have this funny looking beard. I don't have burns on this side. This side is completely burned. And hospital, I don't need to tell you, hospital does lots of things to people. We get to see lots of things. We get to experience lots of new experiences. Needless to say, many of the experiences I didn't like. Most were painful and difficult, complex. There are very few things that I think are as painful as burns. And it's not just that they are very painful, they are painful and continuous. And I started thinking about pain in the beginning, mostly because I wanted to avoid or reduce my own pain, but later, more generally. And that got me to, first of all, I didn't want anybody to have the same pain I did. So that was one. But on top of that, I discovered more and more things down the line. So for example, I remember a day when I visited a very young burn patient. It was a very, very tragic case. He was a young guy who was badly burned in his hands and his face, and he's lost his brother in the same fire. His brother died. And I remember sitting with him in his room, and he was negotiating with the nurse. And as he was negotiating with her, can we do this later? Can we do just part of the body and so on? All the memories of my own negotiation with the nurses came up, and I realized what a difficult experience it was from the perspective of having no control. How difficult it is to be a patient and be at somebody else's hands and unable to control anything. Somebody decides when we're going to get hurt, at what degree, and so on. Very, very painful. So anyway, I think about life in hospital in a very intense way as a magnifying glass for lots of human experiences. I think everybody has feeling of helplessness. Everybody has lots of those things. But if you have it as a burn patient with so much pain for a long time, it calls you for action in a different way. And then if you're experiencing something and I see you hitting your head on something, I have neurons that mimic the activity you had and I can feel some of your pain. Well, I had lots of pains for a long time, and I think I became sensitive to this kind of pain. I don't think I'm sensitive to other kinds of pain, but I think I became sensitive to physical pain, pain that has to do with loss of control, pain that has to do with loss of dignity to the body. And those things I think are staying with me and making me want to help to a larger degree. That's why I'm looking at pain people have and trying to figure out what I can do to help.
I think you also talked about healthcare workers. Have you found any difference for the motivation to work in people who are in helping professions or in healthcare versus other? Are there other like drivers beyond work in general?
When it comes to motivation, I think that most people don't truly understand their own motivation. You know, when you're in something, your motivation is very different from your motivation when you're out of it and thinking about it. And it's true for lots of things where we are thinking about it from an outside perspective, whether from the inside perspective, what we could do, what we're excited, what drives us. And I think with healthcare, it's very hard to understand the motivations unless you try it out. I'm very far from being as effective as health professionals, but I got a few times in my life to help individuals. And it's a dramatic sense of self-perception of improvement and contribution. So I'll tell you, I one of the topics I'm studying these days is end of life. I'm thinking about the last chapter of people's lives from the moment of terminal illness diagnosis until the end of life. And I come at it from my perspective. So I think about what mistakes people do in their chapters and I attacked it in all kinds of ways. I interviewed end-of-life doulas and palliative care physicians and patients and veterinarians, and I took lots of I did some surveys, I did lots of things. And then I became an end-of-life doula. I was so impressed with the end-of-life doulas that I decided to try to do the training myself, and I did the training, and I helped a couple of people. It's not my day job, and I'm not an ordinary end-of-life doula because I do it remotely, and I help with important junction in people's lives. And from the outside, I thought that it would probably be incredibly sad to take this profession because it is about end of life. And there is sadness in it, there's no question. A lot of sadness, but there's also a dramatic sense of contribution and also a kind of urgency about life. And I'm not fully ready to describe it, but there's something about being with the sadness of these wonderful people and saying goodbye to them, and then going and experiencing something that is like a very strange contradiction. And I wouldn't exactly call it happy, but it's a depth of enjoying life that is very different. So anyway, I'm not fully ready to describe it, but it's a fantastically interesting thing. So going back to your question is, do people know what is motivating them? My answer is no. I don't think people are aware about what's motivating them. I think motivation is very complex. And many times we're not good at predicting what will motivate us.
But are there some simple things people can do to maybe get a more narrow perspective, range of things that may motivate them?
So let's say the following. There are some recipes for motivation that are kind of universal. A sense of meaning, a sense of progress, a sense of improvement, a sense of contribution to others, a sense of self. There's lots of things that are like this. If we wrote an equation, we said M for motivation equal, and we wrote all kinds of things in there, there'll be lots of things that we could write. And we could write things that make motivation higher, and we could write things that make motivation lower. For example, bureaucracy. Bureaucracy kills motivation. Because when you create motivation, you tell people, I don't trust you, I don't care about your time, and I don't want you to do anything better than what we've done already. Don't try to do any innovations. And that, of course, kills motivation. A few years ago, I wrote an opinion piece for the Mayo Clinic Journal about physician suicide. I don't know if you know, but there's a very high rate of physician suicide, and it's been increasing a lot compared to other professions. And the question is why? In my analysis in that piece it was about bureaucracy. That you take physicians who are generally there to help people, and then you say, you want to prescribe this medication, we're not going to let you. And the physician can say, yes, but this is the best medication for my patient. Okay, why don't you write a little essay and fill these 19 forms, and then I might approve it, but it will take 6 months. And you take people that are signed up to help, and then you make it impossible for them to help, and you end up crushing motivation.
Yeah, and there is, I think, as a physician myself, and I've led large teams of physicians and other healthcare workers. I think there's this concept of moral injury, which is around people who have got into these professions, and for the most part, they've got into these professions because helping people is what kind of gives them the satisfaction. And as you described, the bureaucracy or the system has been set up intentionally, for the most part, to not let them do the work they're proud of or they feel good about. And I think that over time, it becomes really difficult to stay motivated because you are burning out every day, even if you're working really hard trying to help patients, you're burning out every day um, because you're not able to do the kind of work you want.
By the way, I don't think the system is designed to kill motivation. I think the people who are designing it don't understand motivation. I think that what they say is, this pill costs this amount, this pill costs this amount, I'll just tell people to prescribe this, and they don't have in their models, in their equations, they don't have a role for motivation. I'll give you an example from my world, which is a university. The university is making it very hard to do meaningful research, but there's no accounting on the ideas that are not being carried out. There's no accounting for lack of collaboration. The only accounting is how many people fill this form, how many people did this. So we have a phrase in behavioral economics, you are what you measure. The moment you measure compliance, the moment you pride yourself on, that's what you measure. And in fact, when you deal with people, things are much more complex. But anyway, going to your question, I think there's a lot of things about motivation that we don't do enough of. And if you think about the edges of where we're motivated, it's kind of amazing. People run marathons. Like, you could say marathons are painful. It's suffering. Nobody is smiling as they run a marathon. People climb mountains. People write poetry. If you look at the human condition, we do lots of things that don't look connected to happiness. We do things that are difficult and complex and painful. Go ahead and ask your friend, say, give me the 3 things you're most proud of in your life. My guess that none of them is going to be sitting on the beach drinking mojito for 6 weeks. All of them are going to be things that are complex and difficult and painful, more tears and laughter and so on. We are really motivated by those things. I was recently at the archaeology lab in Israel, some of the most ancient parts of human history. And I got a tour of lots of the labs, coins, clay, and so on, Dead Sea Scrolls. And I asked them, I said, look, you're dealing with very ancient artifacts, some of the earliest we have in the world. How much did those people who created these clay pots or coins or whatever, how much of it were they functional? And how much of it did they care about aesthetics? And the artists in the room didn't agree on the number, but they all agreed that they did lots of things for aesthetics. They say, look, somebody who's creating this clay pot could have done it much faster to just do the job. They cared about their profession. They wanted it to be aesthetic. They wanted to reflect on them. They were not just functional. So I think it's a huge part of humanity. And I think we need to keep it. We need to build it. I'll tell you one other thing. I think that workplaces, are doing injustice to their employees, because I think that they are treating them as labor and not as people with emotions and feeling and motivation. And if you go to a workplace that you hate, let's take an extreme example, everybody's losing. The workplace is losing, you're losing, shareholders are losing, the world is losing. It is so easy. It is so easy to get people to enjoy their workplace. It's a shame we don't do it much more.
So I'll ask you, my area of interest and expertise is actually health system design. And I know you were being a little more generous than I have been recently in thinking that it's not intentional the way it is designed. However, I think if you see the results and how people speak up about this system being designed year after year, I think you have to either say, yes, that's not right, or change. If you keep doing the same thing after being told that this way is not working well, I think then at some point it is intentional. I mean, I see it within health systems that, as you said, you are what you measure. Very critical for many of the health systems. Measures they're taking in account for a patient could be hemoglobin A1C, for example, right? They're tracking hemoglobin A1C for a large population of patients. Yes, it's an important metric, but we know that metric by itself doesn't tell you the patient's story, doesn't tell you much more about the patient at all. However, it helps the health center keep getting funded, right? So the motivation behind what you're measuring in many ways is driving health system funding and not necessarily improve patient outcomes.
I fully agree with you with this view that the measurement a lot of time is not taking things fully into account. Think about something like kids in school. Like, the healthcare systems are strange. I mean, they're so complex and so on. But think about kids in school. Nobody believes that grades are really the best motivation for kids in school. So, if they only had grades, everything would work out. The reality is that we have people in school. It's little people, but it's people, and they are susceptible to lots of motivations. But for some reason, we have this very general view of all we need to do is to set grades and everything would solve itself. And I think with healthcare system, it's much worse because the consequences are very dire. And I'll tell you one other thing. I think that we live in a period where organizations are very fearful. So imagine you gave physicians autonomy, or imagine you gave teachers autonomy. What would happen? There'll be a distribution. Some teachers would excel and some would mess up. If you gave physicians autonomy, Some would do amazing things, some would mess up. The systems we're designing these days are unwilling to accept the mess up, and in their answer to that is let nobody excel. It's kind of no child left behind, is to say, I am not giving physicians any freedom because I don't want anybody to ever disappoint me. Now, you could say, I understand. I understand why you never want to make a mistake. But if you never want to make a mistake, you can't take a risk. You can't try anything new. So and this is true for lots of things. The moment we create procedures and bureaucracies, it's tough. And there's some other similarity between teaching and in medicine, is that in medicine there's this thing called electronic medical records. But everybody that deals with it know that it's really a billing system. It's not a patient's electronic record. It was not designed for that. It was designed for billing. The same thing is true in education. We have lots of systems for schools. They're not designed to motivate the kids. They're not designed to motivate the teachers. They're designed for command and control. And I think this command and control is really killing motivation. Let's take, for example, either teacher or physicians. Different teachers have different strength. Let's say it's literature. One likes Yeats, one likes Woodhouse. I mean, now, do we want everybody to teach Catcher in the Rye? Yes, but if somebody loves Yeats, let them teach Yeats. If somebody likes Woodhouse, let them teach Woodhouse. Why do we need one standard fits all? The same thing is true for physicians. If some physicians are better able to motivate their patients to eat well and exercise, let them do more of that and maybe do less medications. If some physicians are better at surgery, let them. Again, it's not like one size fits all, and the system loves one size fits all.
When I talk to young physicians who are just coming out of residency and training, it's a warning that I give them is healthcare system is very good at showing you this flashy, very high salary positions, and they require you to see more patients an hour than you actually know you can do a good job with seeing them. So when you see a patient and you're able to invest as a human, as a physician, in the time with that patient and really give them your best, then I think the satisfaction you get from doing that work is much different than you would get from seeing many more patients and making a lot more money. You have to get to a place that you decide the kind of work you want, maybe then accept the kind of money you're making, not that you shouldn't be a capitalist and make a lot of money, and then design your life around that. If you buy a Maserati and get a $5 million house, then you're going to have to work 80 hours and possibly have to work in jobs that you're not that excited about.
Yeah, it's more complex than that. So I'll give you an example from Duke. You have physicians, and the government pays them for units of labor. Different units of labor have different costs, and now you're part of a group of physicians. And everyone does procedures and everyone sees patients and there are different units and so on. And all of a sudden, your financial contribution to the group is much more salient. Again, think about couples. Imagine a couple. Imagine one person in the couple makes twice as much as the other one, but the one that makes half is much funnier and much kinder. Now, in the real world, ability to make money is one, being kind and funny is another one. I'm not sure which one is more important above a certain level. But the ability to bring money to the relationship has decimals. It's very precise. The kindness, sense of humor are now. So what happened is that it's very easy to say, hey, we're not equal. But we're not equal on one dimension. It is easy to measure. There are many other dimensions that we're not equal on, but just harder to measure. The moment everything starts to being measured financially, and this is true for units in hospital, you're creating pressure to maximize that. So again, an example from Duke, you have people that contribute by teaching students. You have a group, surgery, let's say, you want them to teach. Some people are better teachers. Some people are better at making money. Some people are better at seeing patients. Some people have a procedure that is now very popular. But the moment you bring people to a group, it creates pressure around the more visible things. So the you are what you measure becomes even extra important.
I'm actually now for the last year working for myself and building a comprehensive dementia program here in San Diego. And I'm thinking the drive towards efficiency for the front line is a disservice to the quality of the patient care that's being delivered. And as you said, they're because the different people are oriented at better at different things. Obviously, this is a deep topic. Like, how does one design a system where the system as a whole is able to not just churn out numbers, but actually work well, but the front line doesn't feel that pressure of the efficiency? Is there a way to actually do that?
So first of all, I think that integrated systems like Kaiser do it better, Mayo Clinic. But I think that what you need is a global optimization. So imagine that we have a hospital with two units to make things simpler. One unit is radiology and one unit is meeting patients. If each of the units has its own P&L and they're just accountable to their own success, you can imagine that the group that sees patients will say, oh, we want to be at 100 capacity. We want to be efficient and so on and reach our goals and so on. And there might be extra capacity to be used in radiology, but we don't care. And that's what happened to lots of organizations, that they stop looking at themselves as one organization and you break things into sub-organization and each organization is just doing their own. I actually got to talk to a big medical device manufacturer and they have lots of statisticians and there used to be statisticians in each group. And then they moved to have a central unit for statistics. Now, if you're working for the statistic unit, you want to be 100% occupied and you never want to wait for a project. So what do? You make the unit smaller and you make everybody else wait for you. Now, if you're designing a new medical device and you have to wait 6 months for the statistical analysis, it's a huge cost for you, but it's not a cost for them. So I think what we need is to remember the organization as a whole and not to break it into component, which is anti-modern management. Each manager is in charge for their own thing. That's one. The second thing is that I think we have to accept some inefficiency on the road for improvements. Look, I think you're in an amazing profession of designing medical systems, but let's agree that when you finish designing a system, a year and a half from now, you need to redesign it because so much has changed. GLP-1, DNA sequencing, new medicines. I mean, things change dramatically. So we need to keep on changing. Now, that's a very hard thing to do for a system. A system, like, think about the systems you helped design. How easy was it to make them flexible?
Extremely difficult. And in fact, what I've also found is when I designed a system for kids with autism, and the same criteria that I initially set out, which in my head was inclusive, a year later, that looked like it's excluding people from the program. And I'm thinking, how did we get here? Because I think for efficiency's sake, it got more and more rigid, and obviously it became more exclusionary than including people.
Yep. So I think one illness is bureaucracy, which is command and control, kill motivation, and so on. I think another illness is creating sub-organizations. I think another illness is reducing the risk people are willing to take. And I think the risk one is very serious because I think that if you don't do anything differently, you'll get what you got yesterday. If you say we need to learn, we need to improve a learning organization, then if somebody says, oh, I'll only accept changes if they'll lead to better results, you don't know. You don't know. So how do you as an organization do that? And so those, I think, are the biggest issues. Now, in healthcare, it's much tougher. I agree. If you have a startup that is dealing with, I don't know what, selling cookies, and you experiment, okay. If you're in healthcare, you experiment, it's a different level of confidence that you need to experiment. But still, you can't say, I'm not going to do it. In fact, if you don't experiment with cookies, nothing terrible will happen. If you don't experiment with health, we're not going to get improvements. By the way, I'll tell you, so I was a burn patient. And when I was a burn patient, they had this thing called the jobs. They had these pressure bandages. So because I had burns all of my body, they gave me this garment. I had a mask for my face, I had a long sleeve shirt, I had gloves, I had pants. Like my whole body was covered. I thought it would be Spider-Man like, but it was brown and kind of a tough fabric that was supposed to press against the scars, like press against them and move them a little bit. That was the theory. And as we were doing this, I said to them, "Are there any papers on this?" It was awful. It was like, just imagine putting on tights all over your body. It's already hot. The body doesn't perspire. It's rough. It's not soft. Hard to move, kind of moving like this. Hard to sleep with it. And I said, "Are there any experiments?" And they said no. And they told me, described how difficult it is to do experiments on this. And I said, my upper thighs don't have any burns. I said, "Why don't you take an iron, put me to sleep, give me 2 burns identical, one on the upper right thigh, one on the left thigh. Let's see, and I'll wear on one and not on the other, but they'll be the same burns." And I said, I think that all burn patients would be willing to participate in experiments because there's a tremendous cost for doing things we don't know if they're correct. Like I felt they were doing all kinds of things that they never got to testing because it was hard to test, but we need to test much more.
I also think because the health systems are designed to not promote the human relationship, the conversation you're describing that you had as a teenager with your nurses, it's for the nurses to initiate that or a physician to initiate that in most settings. It's a difficult conversation to initiate. It's not an easy conversation. In fact, if you're able to have those difficult conversations, you can do a lot more daring and new innovative things with with patients and hopefully find better recoveries than you would otherwise.
Yeah. I think there's a lot. So I told you I'm looking at this question about how people live the last chapter of their lives. In the US, the numbers are more or less that 80% of the people say they want to die at home, less than 30% get to do that. And the reason, there are many reasons for that, but one of them is that we don't listen to patients. Somebody says, I don't want to die in hospital, and then something happened and you send an ambulance and you take them into hospital and you connect them to lots of machines, and it's a very different story to disconnect them.
And then legal teams and ethics teams are making decisions and not physicians and family members often. I want to talk to you a little bit more about end of life work you're doing. So I'm designing a dementia program. One of the reasons I'm working on this is care in this space, especially like many other areas of healthcare, is extremely fragmented. So oftentimes primary care docs, neurology, psychiatry, these 3 fields are working with the patient, but it's not coordinated. The caregiver has extreme amount of stress and not given the support they need. And I also know that the health systems that I've worked in oftentimes unintentionally are not designed to do this kind of work. A patient of mine who actually inspired me to think about this was somebody who did better in the 2 years I was seeing them. And when the last appointment I was talking to them, the family is thanking me, but I told them, my role was probably 5 to 10% of what helped in the recovery, which was really the family was extremely focused on physical activity, socialization, and engaging the patient. I think what I did well in that moment was kind of support and like remind them this is really important and I'm here to help you. I think that was my contribution. I'm really thinking through one, obviously do great clinical care in that setting. However, also look at how can our patients who have been recently diagnosed with dementia or have moderate dementia, how are they planning the next 5 to 10 years of their lives? Like helping them do that actively versus hiding away from the topic of kind of worsening health and death even. So I'm starting to do this work around end of life. Do you feel like that's the right approach?
So a couple of thoughts. First of all, I think that acceptance is a key. Without acceptance, you can't really move forward. And by the way, in the doula training class, there was a very interesting discussion on people with kidney failure. And what they said was that people with kidney failure are hopeful until the last moment that somebody will come and give them a kidney. Sometimes even after they can no longer accept it, but there's this belief that it can all be solved. So their acceptance level is very low. But I think that acceptance is incredibly important. And then I think the discussion is necessary. Now, the way that we have tried to do that is to basically say that the model in which you reach a physician during your quarterly annual checkup, and that's the right time to have that discussion, that's not the right model. So one of the things we did was we hung around with somebody that we think is a very good palliative care physician. And we try to analyze the way he talks to patients. He lets them lead a discussion, and he checks with them how much deeper they want to go. If they don't want to go deeper that day, he doesn't assume they'll not change your mind tomorrow. So we said, okay, let's analyze what a good caring palliative physician does. And now let's do it in an app and not with a person. Why? Because ideally I would want to do it with a person, but I want the person to be available to the patient every day. Like imagine that you have patients with the beginning stages of dementia, and you get to show up at all of their homes in the morning with a cup of coffee. Say, hey, do you want to chat now? I have 5 minutes. If you want more, we'll do more, but do you want to chat now? And sometimes I say, yes, it's a good point now. So when you think about having this discussion, what are the odds that it will be the right time for the patient to have a discussion when they have their quarterly annual meeting with the physician? But if you have the physician in your pocket or a model of the physician, and they say, how did you sleep? Have you noticed anything different? Do you want to talk about that? Now we have the discussion at the terms that are good for the patients. And under those conditions, people are much more willing to have discussions. Now, the other thing is these diseases take a really long time to progress. You don't need to have the discussion all in one time, right? You can have, let's do it slowly. What's the hurry? So the moment you move away from the model that is physician-centered, we all need to do what's easy for the physician, then you say, no, this discussion can last a year, it could progress slowly, it could happen on days when the patient wants to and under their control and when they're more comfortable. And those are the right conditions to have these discussions.
That's a great point because I was thinking through respect and dignity within healthcare for a patient who is at that stage. And initially I thought, oh yeah, giving them the opportunity and giving them the space to do it is key. But then you're also right, which is yes, giving them the space and opportunity is key, but allowing them to do it on their own timeline is another layer of empowerment that's critical.
Yeah. And let me say one other thing. So at the end of life space, there are a lot of times when people say, oh, my father doesn't know he's dying from cancer. Don't mention it to him. And then you talk to the father, he knows he's dying from cancer. So the family, there's all these things that are not talked about, but should be talked about. And I think you need to create a layer that helps that. No, your father knows he's dying from cancer. He wants to talk about this, but not about this, and so on. But the family, these are tough conversations. Like I looked at how physicians break bad news to patients. They don't know how to do it. It's very tough to break bad news. The worst news I broke to somebody was about romantic love and about he got divorced, which was very tough news to communicate and arrive at, and firing people. But all of those are much easier than telling somebody, I can't do anything more for you and your clock is ticking very quickly. How do we expect people to be good at that? We shouldn't. And when you think about families don't have experience having this complex discussion. So how should we just expect all families should be able to know how to do that? Of course not. So we need to guide them. We need to help them. It needs to be mediated. It's kind of not a nice thing to say, but when we die, we're all amateur in dying. It's our first time. I guess, I don't know if you're Hindu, maybe you believe something else, but in principle,
Still an amateur dying, even if I'm in.
we're amateur dying and we don't know how to do it. Our families usually don't know how to do it. And the people in the medical world are supposed to know something to help us how to have these discussions. I think it's incredibly important. I can't tell you how many people I talked to that said that they had parents with dementia and they never had a conversation about do they want to keep on living like this or not. And without having that conversation, they chose to prolong their lives and all kinds of things that they think. When you ask them, truly, would your parents want to do it? They said no, but I'm not sure.
I think one of the things you said is I think having that conversation for a physician or any healthcare worker is not easy. And it is also not meant to be easy. There is no way to make that easy. There's no script you can use because the moment you start using a script, you are immediately not being fully present, right? You're not
That's
engaged
right.
fully. So I think the key here is also the patient has space to do it, but the physician also has the space to do it. I think both are given the space. I'll give you an example. I had a patient a few years ago who came to me. I had been seeing her for a year, and then she came to me right after our 16-year-old kid died by suicide within a week of that. And there's no medical training, there's no statements, none of which could help me in that moment. The only the thing I could do is, okay, I'm another human who's here with you, like trying to talk to you, and hopefully there's some comfort present by us talking about this. I think that's really, if you get down to it, there's no psychiatry training that made me an expert in that moment. But allowing myself and the patient the space and bandwidth to actually talk about this very difficult thing may have helped a little bit.
That's right. Yeah, but you have some experience. You understand dying. You've seen mourning. You can share some things about the process. Absolutely.
And also, I think what I've seen over time is giving the people their space and time to talk about difficult topics is key, but also telling them the truth, as you said, actually saying the difficult thing makes a huge difference in people get relief because for many years they have not been told the truth in how they experience healthcare.
Yeah. Yeah.
Going back to dementia briefly, many of the metrics we currently track for patients with dementia or end of life patients oftentimes are not great at capturing the patient experience and patient progression. They're metrics that the health system needs or the insurance company needs for it to keep going. I really want to get down to like very human experience of the patient and the caregiver and design some metrics that some of them will be general for most patients and some of them may be very specific to that individual patient. How do you go about identifying some metrics which maybe not typical but are actually impactful for this one patient?
Yeah. So I'll tell you what my thought is and some of the things we tried. So people are not supposed to be able to talk in medical lingo. So think about something like advanced directive. We ask people to say, if you stop breathing, do you want to be resuscitated if you stop eating? Like, how do we expect people to answer that question? People have no idea. What percentage of people that are resuscitated break their ribs? How many people last more than 2 weeks? So imagine that they're that we say, look, when we ask people questions that we generally feel that they can answer. Did you have a relative that passed away from life-threatening illness? How long was it? What do you think? What did they want to do? What did you think was good for them? Now that one, I can get lots of insights from it. So I'm thinking about it the following way. I say, imagine that I ask people what they know. Tell me about your experiences, what you've seen, what you think is right, and so on. And then imagine that I use AI to translate that to what physicians say they should have done given that preferences. Like, I don't ask you, do you want to be intubated under those conditions? You're a physician, but somebody who's not a physician. But I would say, okay, if you told me those things, I'll give you an example of my mother. My mother had a sister who had a very tough Alzheimer's. And she said, this is the moment that I don't want to keep on alive anymore. She pointed it out. Now, a physician could take that information and say, here is what she would say, or AI could do that. So I think that we often don't want to take responsibility. So we say, you're the patient, you decide.
Right.
That, I think, is being a chicken morally.
Agreed.
I think that what we need to do is to say to the patient, tell us everything that you can about your views. We, as medical experts, with AI, will help you translate that into an action plan. And then we'll give you the action plan. You can decide, oh, yeah, you can reject it. But when physicians feel for themselves advanced directive, they say no, 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 no to everything. And then they give it to patients who are answering without knowing anything. Instead, what the physician should say, tell me a bit about you, tell me about your experiences, what have you noticed, what's your religious background, what are your beliefs? Now, let me tell you how I would feel it if I were you.
Yeah. I think chicken is the right word because truly sharing your experience or your opinion is often people don't do that, and I think that's critical. Okay.
Very nice to meet you.
Very nice to meet you, Dr. Ariely. Thank you so much. I appreciate your time today. You take care.